Hey class, it's Dr. Jenkins, and in this module we're going to review some antibiotics. There are a lot of antibiotics that you have to know, unfortunately. This is a nice graphic from First Aid that organizes all the antibiotics by their mechanism. And so it is helpful to learn antibiotics based on their class, based on their mechanism, so that you have a general idea of how they work. And this is the kind of stuff that is heavily tested on step 1. It's also helpful to think about antibiotics in terms of their spectrum of activity. So what kind of bacteria can they kill? So this is a really helpful diagram that was created by Dr. Spivak here at the University of Utah. And there's other versions of this floating around out there. But if you look at this here, you can look at specific antibiotics, and it gives you a pretty good idea of what type of bacteria they kill. So if you look at the top, you'll see vancomycin, is really good for Staph aureus, Enterococcus, and strep, and that's it. It's really just a gram-positive cocci antibiotic. Versus if you go down to the red line, carbapenems, they're super broad. They kill staph, they kill strep, anaerobes, gram-negative rods, Pseudomonas, etc. And so this is useful for when you're thinking about what kind of antibiotics you want to prescribe for your patient. The first thing you should be thinking is what's the most likely pathogen, and then you want to pick an antibiotic that's going to actually cover that. Now that last chart was showing kind of basic rules of spectrum, but most hospitals will actually keep track of a local susceptibility report. So they're actually testing these antibiotics and these bacteria to see what works. And so here is just a picture of the University of Utah 2023 report, and they put these out every year. And you can see on the right, a list of different gram-positive cocci and different antibiotics that they'll test these on, and to see how good are these antibiotics. So for example, if you look at Staph aureus, let's specifically look at MRSA. You can see that, no surprise, penicillin, oxacillin, it doesn't work. Vancomycin, however, 100%. Daptomycin, 99%. Trimethoprim sulfamethoxazole, 88%. That's pretty good. Clindamycin, only 76%, so not as good. Doxycycline, 96%. Linezolid, 100%. So these antibiograms are super useful for when you're trying to pick empiric antibiotics for different infections. All right, let's start with penicillin, which is the grandfather of all antibiotics. Penicillin G is the intravenous or intramuscular formulation. Penicillin V is the oral version. And penicillin is a beta-lactam, which means that it has this beta-lactam ring in it, which is highlighted in red. And all beta-lactams are cell wall inhibitors. And so the way they do that is they are structural analogs of cell wall precursors that bind transpeptidase, which is the enzyme that cross-links peptidoglycan chains in the cell wall. So these beta-lactam antibiotics are going to inhibit that process and prevent bacteria that are replicating from building cell wall. But bacteria have evolved to be resistant to penicillin, and that's over millions of years. Bacteria have developed these beta-lactamase enzymes that cleave the beta-lactam ring. So once penicillin was discovered and was starting to be used quickly, we killed off the bacteria that didn't have beta-lactamases, and we're left with a lot of bacteria that do have beta-lactamases, like Staph aureus. So the clinical uses for penicillin are pretty narrow nowadays, but it's still very effective against beta hemolytic streptococcus, especially like group A streptococcus or strep pyogenes. And it's also useful for Neisseria meningitidis, Treponema pallidum, which causes syphilis, and Borrelia burgdorferi, which causes Lyme disease. Now, all beta-lactams have pretty similar side effects, and so that's kind of nice because if you learn the side effects for penicillin, they're pretty similar for all the other beta-lactams as well. So, like most antibiotics, penicillins can cause GI upset, diarrhea, nausea, vomiting. And then they can also cause hypersensitivity reactions. And that's probably the most common side effect you're going to be thinking about when prescribing penicillins is, does this person have a penicillin allergy? Because those are pretty common. And that can manifest as urticaria and other rashes and anaphylaxis. There's also a lot of fake penicillin allergies out there, though, so you really want to ask your patient what kind of reaction they had. A lot of patients think they're allergic to penicillin because maybe a sibling or a parent was, but they've actually never taken penicillin. Another side effect you should know about from beta lactams is interstitial nephritis, and then it can also cause different problems with your blood cells. So you can have an immune-mediated hemolytic anemia, neutropenias, and thrombocytopenias. And then all antibiotics pretty much can cause C. diff, colitis. Beta lactams are no exception. Now, because penicillins, don't work on Staphylococcus aureus, because Staph aureus has beta lactamase, they developed anti-staphylococcal penicillins that are resistant to beta lactamase. And so the IV versions are nafcillin and oxacillin, and there's an oral version called dicloxacillin. And so these anti-staph penicillins are useful against methicillin-susceptible Staph aureus and also Streptococcus species. The main adverse effect you should know for this class is interstitial nephritis. There's a pretty strong association with nafcillin and interstitial nephritis. Now, the next class of penicillins you should know are the aminopenicillins. This is amoxicillin and ampicillin. Ampicillin is the IV version. And these are beta lactams with extended spectrum. And so they are still sensitive to beta lactamases, though, so you can't use them against Staphylococcus. But they can kill anything that regular penicillin can kill, like Streptococcus. And in addition, they can kill Haemophilus, Moraxella, Helicobacter pylori, E. coli, Enterococcus, Listeria, Salmonella, and Shigella. So quite a bit more spectrum was added for these antibiotics. But because there's lots of other resistant organisms out there, we've developed penicillins with even bigger spectrum. These are the anti-pseudomonal penicillins, piperacillin and ticarcillin. The one you'll see the most is piperacillin. And these are used against Pseudomonas, resistant gram-negative rods, Enterococcus, and anaerobes like Bacteroides. Important to note, though, that these anti-Pseudomonal penicillins are still sensitive to beta-lactamases. So there's another class of antibiotics called beta-lactamase inhibitors that can be added to penicillins to increase their spectrum so that it will cover Staph aureus, and it also improves their spectrum against gram-negative rods and anaerobes. And so clavulanic acid is one beta-lactamase inhibitor. It can be added to amoxicillin. Now, I don't generally like to use trade names, but with antibiotics, it's like really hard not to use trade names, and you're going to hear a lot of trade names, and so it is useful to know what the trade names are. So when you add amoxicillin to clavulanic acid, it becomes Augmentin. You may have heard of that one. If you add sulbactam to ampicillin, it becomes Unicin, and if you add tazobactam to piperacillin, it becomes Zosyn. So these are antibiotics that you'll hear used quite a bit. Now, there's another class of beta-lactams called cephalosporins that are resistant to beta-lactamases, so they're really good at killing Staph aureus. Unfortunately, this class of antibiotics has no activity against Enterococcus, so that is something that you should remember. And there's different generations of cephalosporins. So the first generations are mostly going to kill gram-positive cocci like staph and strep, but with each successive generation, you get more gram-negative coverage. It's also important to know that the first and second generations have pretty poor CNS penetration. And so if someone has like meningitis or brain abscess, you're not going to want to use first and second generation cephalosporins. So your first generation cephalosporins are cephalexin, you'll also hear it called Keflex, and cefazolin or cefazolin, also called Ancef, which is every orthopedic surgeon's favorite antibiotic. So the clinical uses are going to be skin and soft tissue infections like cellulitis, and any MSSA infections. So that's methicillin susceptible Staph aureus. So if you have Staph aureus in the blood, endocarditis, osteomyelitis, which is a bone infection, or septic arthritis, these first generation cephalosporins are very good for MSSA. It's also commonly used for surgical prophylaxis. You'll give a dose after surgery to make sure people don't get surgical site infections. The next generation of cephalosporins includes cefuroxime, which can be given IV or orally, cefoxitin, and cefotetin, which are both IV. And these have more gram-negative coverage than the first generation cephalosporins, and so they can be used for things in addition to skin and soft tissue infections like urinary tract infections and pneumonia and intra-abdominal infections. The next class is their third generation cephalosporins, which includes ceftriaxone, which is given IV, cefotaxime, which is also IV, and cefdinir and cefpodoxime. And these have even more gram-negative coverage than your second generation cephalosporins. Ceftazidime is a special third generation cephalosporin that can kill Pseudomonas, but it has less gram-positive coverage than ceftriaxone. And third generation cephalosporins are awesome because they're so broad with their gram-positive and gram-negative coverage. You can use them for just about anything: pneumonia, skin and soft tissue infections, pyelonephritis, meningitis, intra-abdominal infections, endocarditis, and bone and joint infections. And so, when you're on rotations and you don't know, this is especially true if you're like on the inpatient setting or in the emergency department, if you don't know what antibiotic to give a patient, there's a pretty decent chance that ceftriaxone is the right answer. And that's why ceftriaxone is probably my favorite antibiotic. It's useful for so many different infections. So it's not always the right answer in real life or on exams, but like I said, if you don't know what antibiotic to give a patient, ceftriaxone will probably work. You also have your fourth generation cephalosporins, which is really just one cefepime. And these cephalosporins are good for killing Pseudomonas. So if you're worried about Pseudomonas or nosocomial infections, cefepime is a good option. It's also used for neutropenic fever. The main side effect you should know that's unique for cefepime is neurotoxicity. So there was an interesting trial in 2023 that compared cefepime to piperacillin tazobactam, and there was a lot more neurotoxicity in the cefepime arm. And that can be headache, delirium, and seizures. And so something to be aware of, especially in patients with poor kidney function. Watch out for that neurotoxicity. Your fifth generation cephalosporin is kind of an odd duck. This is ceftaroline, and it's a cephalosporin that can kill MRSA. It also covers Enterococcus faecalis. But its gram-negative rod coverage is pretty similar to ceftriaxone, so it doesn't cover Pseudomonas. So really, you're just going to pull this guy out when you need something to kill MRSA, is generally when ceftaroline is used. And I would say generally the use is restricted, like you need an infectious disease consult to use this antibiotic. The next class of beta-lactams you should know are the carbapenems. These are very broad-spectrum beta-lactams and resistant to beta-lactamases. The first prototype was imipenem, which is given with cilastatin, which inhibits its activation in renal tubules. The other one you'll see the most commonly used is meropenem, and then ertapenem is a nice carbapenem that you can use because it's only once a day, but you should know that ertapenem does not cover Pseudomonas, so that's one important gap. Clinical uses, it's really broad. It can kill gram-positive cocci, not MRSA, as well as anaerobes, and it can kill gram-negative rods, including extended spectrum beta-lactamase producing organisms. So, a lot of bacteria make beta-lactamases. Now we've got these super bacteria that make extended spectrum beta-lactamases where they're resistant to most antibiotics. Carbapenems can kill ESBL producing organisms. So if you have a patient with a history of ESBL producing organisms coming in with some kind of infection, typically you're going to start with a carbapenem. The adverse effect you should know for carbapenems is they can cause seizures, especially imipenem. And the last beta-lactam you should know is aztreonam. This is called Amonobactam. It is resistant to most beta lactamases, and it's used exclusively for gram-negative rod infections. So it really doesn't kill gram-positives or anaerobes, but it's something that you can use for gram-negatives in patients who have severe penicillin allergies. So where maybe you wanted to use piperacillin tazobactam to kill Pseudomonas, they have a penicillin allergy, you can use aztreonam instead. Vancomycin is a different type of cell wall inhibitor. It inhibits cell wall peptidoglycan formation by binding to the D-ala portion of cell wall precursors, and it's a pretty awesome antibiotic because it's really good at killing MRSA and other gram-positive cocci. You can also use oral vancomycin for C. difficile. The side effects you should know for vancomycin are that it can cause kidney injury, nephrotoxicity, and it can cause this classic vancomycin flushing syndrome, which is histamine mediated. So you can pre-treat with antihistamines if you need to, and it also is prevented if you just infuse it slowly. So if you give a patient vancomycin and they develop this flushing syndrome and turn red, it's not like an anaphylactic reaction. It is kind of a typical reaction to vancomycin that you can just slow down the infusion, and they usually do okay. Daptomycin is a newer antibiotic that was designed also to treat gram-positive infections. It's a lipopeptide that disrupts cell membranes of the gram-positive cocci, and it creates these transmembrane channels. So you're mostly going to be using it for MRSA infections, and that could be skin and soft tissue infections like cellulitis and abscesses, but also for bacteremia and endocarditis. And it's useful if you have vancomycin-resistant enterococcus. You should know that daptomycin is inactivated by surfactant in the lungs, and so you shouldn't use it for patients with like MRSA pneumonia. And the main adverse effects you should know for daptomycin are that it can cause muscle injury, including myopathy and rhabdomyolysis. And so typically if you start daptomycin, you're going to get a baseline creatine kinase, and you're going to monitor that on a weekly basis while the patient is on daptomycin. Linezolid is another antibiotic that was developed to treat gram-positive cocci. It inhibits protein synthesis by binding to the 23S rRNA of the 50S ribosomal subunit to prevent formation of the initiation complex. It's mostly used for MRSA and vancomycin-resistant enterococcus. Its main adverse effects are bone marrow suppression, especially low platelets. It can cause peripheral neuropathy, and because it inhibits monoamine oxidase, it can cause serotonin syndrome in patients who are on other serotonergic drugs, although we've probably overestimated how common that actually will happen. It's pretty uncommon. And so it is good to be aware of, though, if someone's on a lot of serotonergic drugs, maybe talk to your pharmacist before starting linezolid. Tetracyclines are a class of antibiotics that also bind to ribosomal subunit, in this case the 30S portion. And there are tetracycline, doxycycline, and minocycline. Doxycycline is the one you'll probably see used the most. It's important to know that this one should not be taken with milk, calcium, magnesium, or iron because divalent cations can inhibit the absorption of the drug in the gut. The most common places you'll see this drug used would be for like Lyme disease, atypical pneumonias like mycoplasma, chlamydia. It's good for rickettsial infections, and it's an oral drug that kills MRSA. So that's nice to know. Adverse effects, it can cause GI upset, pill esophagitis. So you definitely want to take it with a lot of liquid. If it gets stuck in your esophagus, it can kind of burn a hole. And it causes light photosensitivity. We don't use it in kids or pregnant women because it causes inhibition of bone growth, and it can cause pretty severe teeth discoloration. Clindamycin is an antibiotic that blocks peptide transfer or translocation at the 50S ribosomal subunit. And it is mostly used for gram-positive cocci and anaerobes. And we typically say anaerobic infections above the diaphragm, so aspiration pneumonia and lung abscesses, or oral and dental infections. Dentists really like clindamycin. But it's also effective against Streptococcus pyogenes and is classically used in people who come in with like toxic shock-like syndrome from strep. It does have some MRSA coverage as well, but the susceptibility is variable, so you should know what your local susceptibility is. Here at the University of Utah, it's about 75%, so not the best option for empiric treatment of MRSA, but if you know the susceptibility for the MRSA, you can use clindamycin. Adverse effects is pretty tough on the stomach, so most patients will have pretty significant GI upset, diarrhea, and it's classically associated with a higher risk of C. diff colitis. Macrolides are antibiotics that bind the 50S ribosomal subunit. They include azithromycin, clarithromycin, and erythromycin. You're mostly going to see it as azithromycin, and it's used for atypical pneumonias like mycoplasma, chlamydia, Legionella, and Bordetella, which is whooping cough. You can also use it for streptococcal infections in patients with penicillin allergy. And then we'll frequently use it in cystic fibrosis and COPD exacerbations, and it's also used to treat Mycobacterium avium intracellular, or MAC, and it can be used for prophylaxis against MAC in patients with AIDS. The adverse effects of macrolides are increased GI motility, so it can cause nausea and diarrhea. Sometimes we'll use that to our benefit. So like if someone comes in with a GI bleed and they have a lot of blood in their stomach, you can give them IV erythromycin, and that will actually help them move their stomach and bowels to get the blood out of there before they have endoscopy. They also cause a prolonged QT, and so that's something to be aware of if they're on medications that prolong QT. If you add the macrolide, you probably want to monitor that closely so they don't develop torsades. And then it's important to know that clarithromycin and erythromycin inhibit cytochrome P450 in the liver, so that can affect drug-drug interactions. Trimethoprim sulfamethoxazole, TMP-SMX, also called Bactrim, is a combo drug that sequentially blocks folate synthesis, and it is used for a lot of different things. Urinary tract infections is one of the big ones, as well as skin and soft tissue infections, because it does have activity against MRSA. It's also used for nocardia, and the other important place it's used is for pneumocystis jirovecii, both as treatment and prophylaxis. So if you have a patient with AIDS who needs pneumocystis prophylaxis, usually you're going to use trimethoprim sulfamethoxazole. And if you have a patient who actually has the pneumonia, you would also use that as treatment. Has a lot of adverse effects, so even though it's a pretty awesome antibiotic for killing bacteria, I don't love Bactrim because of its side effects, but sometimes it's your best option. So the trimethoprim component can cause hyperkalemia because it blocks ENaC. It also increases your creatinine, which isn't necessarily nephrotoxic, but it can look like they have a kidney injury if their creatinine bumps when they take this medication. It also causes, because of its effect on folate synthesis, it can cause leukopenia and megaloblastic anemia. The SMX component can cause hypersensitivity reactions, especially if they have sulfa allergy, can cause interstitial nephritis, and the worst thing is Stevens-Johnson syndrome. Also causes kernicterus in infants and hemolysis in people with G6PD deficiency. Fluoroquinolones are an awesome antibiotic, ciprofloxacin, levofloxacin. They inhibit topoisomerase 2, also called DNA gyrase, and topoisomerase 4. They're really good for gram-negative infections, and sometimes they can kill Pseudomonas. So you have to know your susceptibilities, but they're the only oral antibiotic really that can kill Pseudomonas. Levofloxacin also has strep coverage, so it can be used for pneumonia. But they have a lot of adverse effects, and bacteria become resistant to them very quickly. So they cause GI upset, and then really severe issues with tendons, so tendinitis and tendon rupture because of the effect on like collagens. You can also have aortic dissections from fluoroquinolones. They can prolong the QT, and they're teratogenic, so you can't use them in pregnant people. Generally, we don't use fluoroquinolones unless it's our only oral option to treat a bacteria. Metronidazole is an antibiotic that damages DNA by forming toxic free radical metabolites in the bacterial cell, and it's really useful for protozoa like Giardia, Entamoeba, and Trichomonas, and our anaerobic infections, including Gardnerella, Bacteroides, Clostridium, Fusobacterium, and Prevotella. So if you have a patient with an intra-abdominal infection where you're worried about anaerobes, or like a diabetic foot infection that's polymicrobial and you need anaerobic coverage, you can use metronidazole for that. It does have a lot of side effects. If you drink alcohol while taking it, you can have a disulfiram-like reaction. It also causes GI upset, headache, and metallic taste. Nitrofurantoin is an antibiotic that we don't fully understand the mechanism, but it inhibits DNA, RNA, and cell wall synthesis. It has activity against staph, strep, enterococcus, and gram-negative rods, including some ESBL-producing bacteria, but has no activity against Pseudomonas or Proteus. It's concentrated in the urine, but it has very poor tissue penetration. So it's really only used for cystitis or bladder infections. It's not going to get to the other tissues. So really, this is the only time we use nitrofurantoin is for urinary tract infections. Adverse effects include hemolysis with G6PD deficiency, and if people take it long term, like some people will take it for prophylaxis against urinary tract infections, it can cause pulmonary fibrosis. Uh, there's some other antibiotics that you should probably know for like step 1 or step 2 or your shelf exams. These are not antibiotics that you're going to see used as frequently in your clinical rotations, but you should still be aware of them because they have interesting mechanisms and side effects, but didn't think they were worth covering today. All right, well, thanks for your attention.